Candida is a yeast-like fungus, which is part of the normal commensal flora of the human gastrointestinal tract. Colonization with Candida is usually asymptomatic. However, where mucosal barriers are disrupted or if the host defenses are lowered, it can cause infections, candidiasis, ranging from non-life-threatening superficial mucocutaneous disorders to invasive disseminated disease involving multiple organs. Severe disease is associated with an immunodeficiency, e.g., malignancy, HIV infection, or immunosuppressive therapy. The most common forms of oral candidiasis are pseudomembranous candidiasis, often called oral thrush, erythematous candidiasis, also known as atrophic oral candidiasis, denture stomatitis, and angular cheilitis. Other forms include hyperplastic oral candidiasis, plaque-like oral candidiasis, and median rhomboid glossitis. Causes and risk factors. There are over 20 Candida species that can cause infection in humans. Oral candidiasis is most commonly caused by Candida albicans, although it can occasionally be caused by other Candida species, such as C. glabrata, C. cruzi, and C. tropicalis. Oral candida may be described as a disease of the diseased, an opportunistic pathogen. Risk factors for oral candidiasis include extremes of ages due to immature or weakened immunity. In addition, saliva is known to be protective, and elderly people are more likely to have reduced salivary flow, xerostomia, which increases their risk. Immunocompromise or systemic immunosuppression. This covers a wide spectrum of conditions, including hematological cancer, for example, acute leukemia, chemotherapy and radiotherapy for the treatment of cancer, HIV infection and AIDS, recent or concurrent use of drugs that promote candle growth, particularly broad-spectrum antibiotics and inhaled or oral corticosteroids. Diabetes mellitus, types 1 and 2. Chronic hyperglycemia is associated with impaired wound healing and higher susceptibility to infections. Other endocrine disorders or disturbances, including undiagnosed hypoendocrine states, such as hypothyroidism or Addison's disease, and pregnancy due to reduced effectiveness of the immune response. Dental prostheses, possibly due to enhanced adherence of Candida to the acrylic, ill-fitted appliances, decreased saliva flow under the denture surfaces, or inadequate hygiene. Poor dental hygiene. Dental caries is associated with candidiasis, and expert opinion is that regular oral and dental hygiene with periodic oral examination will prevent most cases of oral candidiasis. Local trauma, including mucosal irritation. Smoking. This is regarded as a significant cause of oral candidiasis, particularly median rhomboid glossitis, and smoking cessation alone may clear infection in these people. Poor diet. Unbalanced dietary intake of refined sugars, carbohydrates, and dairy products containing high content of lactose might serve as growth enhancers by reducing the pH levels and hence favoring overgrowth of Candida. Nutritional deficiency. Iron is the most common deficient essential micronutrient implicated in the colonization of Candida, as iron deficiency diminishes the fungistatic action of transferrin and other iron-dependent enzymes. Other nutrients frequently deficit in chronic candidiasis include essential fatty acids, folic acid, vitamins A, B6, and B12, magnesium, selenium, and zinc. Impaired salivary function, reduced or absent salivation can predispose to oral candidiasis, as the antimicrobial proteins in saliva prevent candle overgrowth. Complications. Oral candidiasis can cause chronic pain and/or discomfort, impaired speech, impaired eating, chewing, thereby limiting oral intake of fluids and nutrition. In people who are severely immunocompromised, oesophageal candidiasis may develop, causing dysphagia, difficulty in swallowing, and/or odonophagia, painful swallowing. The infection can spread through the upper gastrointestinal tract or blood, leading to severe systemic invasive candidiasis. Candidemia, the presence of Candida species in the blood, is the most common manifestation of invasive candidiasis. Systemic invasive candidiasis is a serious infection that can affect the heart, central nervous system, eyes, bones, and joints, leading to sepsis and/or organ-specific infections, such as pneumonia, meningitis, endocarditis, and mucocutaneous osteoarticular, hepatosplenic, and peritoneal infections. It has an estimated mortality rate of up to 79%. Prognosis. The clinical course of candidal infection depends on the type of candidiasis and the presence of any associated risk factors. Generally, in most people, untreated candidiasis persists for months or years unless associated risk factors are treated or eliminated. In neonates, spontaneous cure of oropharyngeal candidiasis usually occurs after 3-8 weeks. In HIV-positive people, protease inhibitors used in highly active antiretroviral treatment regimens have been shown to directly attenuate the adherence of Candida albicans to epithelial cells in vitro by inhibiting the action of Candida virulence factors. The diagnosis of oral candidiasis is usually made by identifying clinical features and excluding other differential diagnoses. Clinical features vary according to the type of candidal infection. Types of oral candidiasis. Pseudomembranous oral candidiasis, oral thrush, presents with patches of curd-like, white or yellowish plaques that can occur anywhere in the mouth, especially the cheeks, gums, palate, and tongue. These are easily removed, revealing an underlying red base that is not usually painful. Symptoms of acute pseudomembranous oral candidiasis are minimal, burning and itching sensation. However, chronic forms may involve the esophageal mucosa, leading to dysphagia and chest pain. It most commonly occurs in neonates, elderly people, people who are immunocompromised, especially people with AIDS, diabetes, cancer, or taking broad-spectrum antibiotics, and people with xerostomia. Acute erythematous oral candidiasis, acute atrophic oral candidiasis, presents with marked soreness and erythema, particularly on the palate and dorsum of the tongue. The filiform papillae disappear, and the dorsal surface of the tongue appears smooth. It is usually asymptomatic or is accompanied by a mild burning and itching sensation. It is the most common presentation in both immunocompromised and immunocompetent people, and commonly occurs after treatment with oral antibiotics. Denture stomatitis, chronic erythematous candidiasis, or chronic atrophic oral candidiasis presents with redness and rarely soreness in the denture-bearing area. It affects about 50-70% of denture wearers. Angular cheilitis presents with redness, fissuring, and soreness at the angle of the mouth. It may be caused by bacterial infection, mainly Staphylococcus aureus, as well as yeast, Candida species. It tends to occur in older people, particularly those with reduced facial height or with ill-fitting dentures, younger immunocompromised people, and people with anemia or vitamin B12 deficiency. Chronic plaque-like oral candidiasis, chronic hyperplastic candidiasis, can manifest in nodular form or as white plaques on the cheek or tongue that are not easily removed. In this form of the disease, the Candida hyphae are not only found at epithelial surface level, but also invade deeper levels where epithelial dysplasia can be observed. It presents with mild symptoms, but has an associated increased risk of malignancy. It is most common in men older than 30 years of age and in smokers. Median rhomboid glossitis presents with a central, red, demarcated area of papillary atrophy of the tongue, from the posterior midline just anterior to the circumvallate papilla. It affects less than 1% of the population and is usually seen in males, smokers, people using corticosteroid inhalers, and people with diabetes. It can lead to recurrent or chronic atrophic candidal infection. Swabs to detect C. albicans or antibody serology are not thought to be diagnostically helpful as candidal organisms are a normal commensal found in many healthy people. Oral carriage of Candida is reported to be 45 to 65% in healthy children, 45% in neonates, 30 to 45% in healthy adults. Differential diagnoses oral candidiasis include erythema migrans, also known as geographic tongue or benign migratory glossitis, an inflammatory disorder affecting 1-3% of the population. It is associated with atopic conditions and psoriasis, and is characterized by central erythema caused by atrophy of the filiform papillae and surrounding slightly elevated white-yellow borders, hairy tongue, accumulation of excess keratin, on the filiform papillae of the dorsal tongue, leading to the formation of elongated strands that look like hair. The color of the tongue can range from white or tan to black. It occurs most commonly in smokers, people with poor oral hygiene, and people who overuse mouthwashes. Leukoplakia, a white patch or plaque on the mucosa that cannot be rubbed off. It may be caused by chronic exposure to irritants, particularly tobacco or chronic infection, particularly oral candidal infection. It is most commonly a benign condition, but may be premalignant. Lichen planus, an inflammatory condition that affects 1 or 2% of adults. There are two main types. Reticular lichen planus is characterized by bilateral, asymptomatic, white, lacy striations or papules on the posterior buccal mucosa. This form is easily identifiable and does not usually require further investigation. Erosive lichen planus manifests as zones of tender erythema and painful ulcers surrounded by white, radiating striae, and may require biopsy to rule out serious causes. HIV infection. Unexplained oral candidiasis is an HIV indicator condition. Oral cancers, including squamous cell carcinoma. Early lesions are often asymptomatic, appear as areas of erythroplakia, red patch, or leukoplakia, white patch, and may be ulcerated or exophytic, growing outwards. As the lesion grows, it becomes more symptomatic. Melanoma. The oral mucosa is primarily involved in less than 1% of melanomas. Lesions are largely macular, but may be nodular or pedunculated. The pigmentation varies from dark brown to blue-black. However, mucosa-colored and white lesions may be seen, and erythema is observed when the lesions are inflamed. The palate and maxillary gingiva are involved in about 80% of people, but buccal mucosa, mandibular gingiva, and tongue lesions are also identified. An amalgam tattoo, an iatrogenic lesion caused by traumatic implantation of dental amalgam into soft tissue, can sometimes be mistaken for melanoma. It is the most common localized pigmented lesion in the mouth. Kaposi sarcoma, discolored patches, and occasionally nodules that are usually red or purple and look similar to bruises. Chemical or thermal burns. These should be straightforward to distinguish with adequate history taking, e.g. aspirin used for toothache. Investigations. Swabs, culture, and serology are generally not useful because candidal organisms are commonly found in healthy people. Swabs may be relevant for suspected drug resistance, e.g., in HIV-positive patients. Oral candidiasis management in a child younger than 16 years of age. Admit the child if there is evidence of systemic illness, candidemia. There is widespread infection, such as oesophageal candidiasis, characterized by difficulty or pain on swallowing or retrosternal pain. Refer to a pediatrician or seek specialist advice if the child has extensive or severe oral candidiasis. If the child can be managed in primary care, exclude risk factors for oral candidiasis, such as diabetes, haematinic deficiencies, and poor dental hygiene. Oral candidiasis is uncommon in people other than infants, denture wearers, and the elderly. In otherwise healthy people, it may be the first presentation of an undiagnosed risk factor. Prescribe topical antifungal treatment for 14 days. Offer miconazole oral gel first line for children aged 4 months and over unlicensed for use in a child aged younger than 4 months, or 5-6 months for an infant born preterm. If miconazole oral gel is unsuitable, offer oral nystatin suspension unlicensed for use in neonates. After 7 days, change to nystatin suspension if not responding to miconazole gel. Infants. Note that miconazole gel is not licensed for age less than 4 months. However, some doctors feel this is an unnecessary limitation. It arose from concerns about choking if the gel is administered incorrectly to young babies. Although noting it is not licensed for use less than 4 months, the British National Formulary, B and F, states the dose for neonates and from 1 month to 1 year. The correct method of use is to smear 1 milliliter for neonates, 1.25 milliliters for babies aged 1 month to 1 year of miconazole oral gel around the mouth and gums with a finger after feeds 4 times a day. Give appropriate lifestyle advice to aid healing and prevent recurrence. In particular, advise on good dental hygiene. If the child is using an inhaled corticosteroid, advise the following. Good inhaler technique: rinsing the mouth with water or cleaning the teeth after inhalation to remove any drug particles, using a spacer device to reduce the impaction of particles in the oral cavity, and stepping down the dose of inhaled corticosteroid when appropriate. Refer to a pediatrician or seek specialist advice if the child does not respond adequately to at least 2 weeks of treatment with miconazole and/or nystatin, has recurrent episodes of oral candidal infection, or there is suspicion the child is immunocompromised. Oral candidiasis management in people age 16 years or older. Admit the person if there is evidence of systemic illness, candidemia. There is widespread infection, such as esophageal candidiasis, characterized by difficulty or pain on swallowing or retrosternal pain. If the person can be managed in primary care, exclude risk factors for oral candidiasis, such as diabetes and hematinic deficiencies. Prescribe antifungal treatment. If the infection is mild and localized, prescribe topical antifungal treatment for 14 days. Offer miconazole oral gel first line. If miconazole is unsuitable, offer nystatin suspension. If the infection is extensive or severe infection, consider one of the following. Prescribe fluconazole 50 milligrams a day for at least 14 days. Seek specialist advice or refer to an oral surgeon. Give appropriate lifestyle advice to aid healing and prevent recurrence. In particular, advise on good dental hygiene. If the person is a smoker, offer advice on smoking cessation. If the person is using an inhaled corticosteroid, advise the following. Good inhaler technique, rinsing the mouth with water or cleaning the teeth after inhalation. To remove any drug particles, using a spacer device to reduce the impaction of particles in the oral cavity, and stepping down the dose of inhaled corticosteroid when appropriate. If the person wears dentures, advise them to leave the dentures out for at least 6 hours in each 24-hour period to promote healing of the gums. If the gums are inflamed, they may benefit from the dentures being left out for longer. Clean dentures by brushing and then soaking them in a disinfectant solution, for example, chlorhexidine or hexadine ironite. The dentures can be soaked in any solution marketed to sterilize babies' bottles, providing the dentures contain no metal. Allow the dentures to air dry after disinfection. This also kills adherent candida. Brush the mucosal surface regularly with a soft brush. See a dentist to correct ill-fitting dentures. If the person has diabetes, review diabetic control and manage accordingly, particularly if there are recurrent episodes of oral candidiasis. For people taking a sulfonylurea, such as glycolide, be aware of drug interactions with miconazole or fluconazole. For people taking warfarin, be aware of the drug interaction with miconazole. Do not prescribe miconazole to people who are taking a statin. Use nystatin. Follow-up. Follow people who have extensive or severe oral candidiasis requiring oral fluconazole after 14 days. If the infection has completely resolved, stop treatment. If the infection has not completely resolved, consider the following. Extend the course of fluconazole for a further 7 days. Refer to an oral surgeon if the infection persists after this. Swab to identify the causative organism. Seek specialist advice or refer to an oral surgeon. Use clinical judgment. Taking into account the severity of infection, there should be a low threshold for early referral if infection is severe, the level of immunocompromise, and the response to treatment. Also consider referring to an oral surgeon or seeking specialist advice if the person has recurrent episodes of oral candidiasis. The person has breakthrough candidal infection while receiving preventive treatment, which may indicate candidal resistance. There is doubt about the diagnosis. Consider referring for biopsy people with chronic plaque-like oral candidiasis that is unresponsive to treatment, as it carries a risk of malignancy. Oral candidiasis management in adults who are receiving treatment that may cause immunosuppression, including oral corticosteroids, disease-modifying anti-rheumatic drugs, DMARDs, and chemotherapy and/or radiotherapy. Seek specialist advice before starting antifungal treatment if the person is taking cyclosporin or oral tacrolimus, especially if these drugs are being used to suppress tissue rejection following transplantation, receiving chemotherapy. For people taking oral corticosteroids or disease-modifying anti-rheumatic drugs, DMARD, if the infection is mild and localized, prescribe topical treatment for at least 14 days and continue until 2 days after symptoms clear. Offer miconazole oral gel first line. If miconazole is unsuitable, offer nystatin suspension. Nystatin may be preferable when considering possible adverse effects. Candidiasis persisting after 7 days of treatment. If not responding to miconazole, change to nystatin. If taking fluconazole, continue treatment for another week. If the infection is extensive or severe, consider one of the following options. Prescribe oral fluconazole 50 to 100 milligrams a day for 7 to 14 days. Seek specialist advice or refer to an oral surgeon. If there is suspicion that DMARDs are causing marked immunosuppression, seek specialist advice and ensure blood parameters are being adequately monitored. Oral candidiasis management in adults who are HIV positive. Admit the person if there is evidence of systemic illness, candidemia, there is widespread infection, such as esophageal candidiasis, characterized by difficulty or pain on swallowing or retrosternal pain. Lower the threshold for admission in people who are markedly immunocompromised. Management in primary care. Prescribe oral fluconazole 200 milligrams on day 1, followed by 100-200 mg daily for 14 days provided the person is otherwise well and is not taking prophylactic antipsychotic treatment. Seek specialist advice before starting treatment if oral candidiasis is extensive or severe. Treatment with fluconazole for a previous episode of candidiasis was ineffective. Give appropriate lifestyle advice. In particular, advise on good dental hygiene. If the person is a smoker, offer advice on smoking cessation. Also consider referring to an oral surgeon or seeking specialist advice. If the person has breakthrough candidiasis while taking preventive treatment, this may indicate candidal resistance. The person has recurrent episodes of oral candidiasis. There is doubt about the diagnosis. Consider referring for biopsy people with chronic plaque-like oral candidiasis that is unresponsive to treatment, as it carries a risk of malignancy. Esophageal candidiasis management. Treatment is usually advised by secondary care. Consider admission to hospital. Esophageal candidiasis can be a life-threatening infection. Treat for 14 to 21 days. The following treatment options are suggested. First-line treatment options. Oral fluconazole, 200 to 400 milligrams daily. If oral treatment cannot be tolerated, intravenous IV fluconazole or an echinocandin, e.g., caspofungin or micafungin. Second-line treatments are oral itraconazole oral solution, oral posaconazole or IV, or oral voriconazole. For AIDS patients, antiretroviral therapy is advised to prevent recurrence.